Well, good morning again, everybody. Bruchim habayim. Welcome. It's really wonderful to be here with all of you this morning. I recognize a fair number of faces here, both on the Massachusetts side and on the Israeli side. I don't recognize everybody, but I hope to meet many of you throughout the day. My name's Kevin Tabb. I'm the president and CEO of Beth Israel Deaconess Medical Center in Boston. But I really am here to say how excited I am that we're here with all of you. I'm excited about the coming together of a variety of different constituents. Now, the word constituents means many different things. There are constituents in Massachusetts of the governor, but also a variety of different pieces that really today do work together and can work together even more closely. As somebody myself who is both an Israeli and an American, a physician, but also in my prior life an entrepreneur in digital health, and now a potential consumer of the ideas and the products that many of you are thinking about and producing, the potential is huge. We've got three very interesting panels, I think, today that speak to digital health and the complexities of digital health, what it takes to be successful, and also the intersection of digital health and cybersecurity. And I'd say that those two pieces, digital health and cybersecurity, those are the reasons that we're here as a delegation. But those two pieces have always been linked. They've never been more inextricably linked than they are today, though. And we'll hear about that a little bit later. We've got here a combination of hospital CEOs and venture capitalists, heads of large digital health companies and small startups, all ready and willing to talk about what we can do together and what would make it, what would success look like. I won't, one of the things I've learned over the last few days in listening to the governor speak is that brevity is important. So I've learned something, and I won't speak any further except to say that I believe that Massachusetts, Boston particularly, but Massachusetts in general, offers a really unique and unparalleled opportunity for anybody that's interested in digital health. The intersection of healthcare and education is not like anywhere else in the world. The number of people that are thinking about great things there is like nowhere else. I believe that if you can make it in the Massachusetts environment, you can make it anywhere in the world. So we'll talk about that more a little bit later. But again, welcome to everybody for being here this morning. And I think we're looking forward to a really fruitful day. Thank you. That's it.
So good morning, everybody. My name is Retsef Levi. I'm a faculty at the Sloan School of Management at MIT, and was born in Israel, and still most of my adult life spent here. And it's my pleasure today to host the first, to manage the first panel. We're going to have three very, very experienced and qualified people on the panel that understand healthcare in general, healthcare in the U.S. in particular, and from different angles. So let me start by introducing them. So Kevin Tabb is currently the CEO and president of Beth Israel Deaconess Medical Center, one of the most prestigious academic medical centers in the world, and one of several prestigious academic medical centers that the Boston area hosts. He's also, in his past, has experience with health IT and health innovation. So again, as I said, brings multiple perspectives to the topics that we will discuss today. Our second panel member is Michael Greeley. He is currently the general partner at Flare Capital Partners, and he's also holding several board seats in healthcare startups. Just to name a few, Health Verity and Iora Health. Again, bringing experience of on healthcare from the IT perspective, from the delivery perspective, and I think we'll add unique perspective here. And then the last panel member is Carl Bayer. He's currently an executive partner in F Prime Capital Partners, and he is he was in the founding team of Athenahealth, a large health IT company that is again hosted in the located in the Boston area. He's also teaching in the Harvard Kennedy School. So again, multiple perspectives. What we're going to talk about today is the aspect of the prospect of digital health. And what I want to do first is to start by trying to bring everybody on the same page with respect to the vision of what do we mean 10 years from now when we think about the digital health. It's fair to say that when you ask different people, you're going to get different answers, and often the answers are going to be talking about data, taking out your mobile phone and talk about an app. But what I would like to do is to try and give maybe a more system perspective for the notion and the vision of digital health that has to do with industry transformation. And maybe to do that, I want to call out two examples, probably not the only examples, of other industries that went through maybe somewhat similar transformation. So the first example is the financial services and banking. Ask yourself, when was the last time you visit your bank branch? So this is an industry that used to be working based on a very slow pace, discrete engagement with the customers, with the consumer, mostly face-to-face and over the phone, and somewhat transformed to an industry that provides online services, very personalized, leveraging analytics and sophisticated algorithms to actually make decisions, sometimes in completely automated way. Completely transformed the way we think about it, the outcomes, the customer-driven outcomes. Maybe another example is the media industry. So think about, when is the last time you read a printed newspaper? We used to get media in a very discrete manner through printed products. Now we get it on our mobile phones, personalized to us, to our needs, to what we actually are interested in. Again, leveraging analytics to understand what we need, to figure out what will be best to deliver to us. Another industry that was transformed by the digital area. The question that I'm asking is healthcare going to be the same? Because the current state of affairs of healthcare is pretty much similar to where these industries were. It's an industry that is designed to provide discrete care to sick people in a very reactive manner in very confined locations like clinics and hospitals. And the question that I'm asking the panel members, is it just a matter of time? 10 years from now, are we going to see the health industry in a very same place that these transformed industries are currently at? Or there are some unique aspects to healthcare that might bring different results or different scenarios. And I want to start with Kevin, asking you to reflect on that vision and what does it mean to you as the CEO of a major academic medical center?
So, sorry, is this on? Can people hear me?
Oops, sorry.
Okay, is it on now? Yeah. All right. So this question of is healthcare similar to other industries? Other industries have been digitalized. Why haven't we been digitalized to that extent? It's been around for a really long time. And I'd say the short answer is that we in healthcare have frequently hidden behind a bunch of excuses about why we're different. And there are, of course, many things that are different between healthcare and finance. It is complicated, but we're not that different. I think many of those things are different. Many of those things are the same, sorry. At the same time, the larger question of why haven't we changed and fully adopted digitalization is an open one. There are all sorts of, over the years, accusations that have been made that doctors are Luddites. I don't think that's true. That the incentives are not appropriately optimized for us to adopt. I'd say that's an excuse too. I think that we have not yet seen truly transformative offerings made to us. And if we ever saw them, we'd adopt them, and we'd get beyond the excuses. I think if we think 10 years out, there are going to be a lot of changes for hospitals, for healthcare, some of it related to IT and some of it not related to IT. The best example that I can give isn't directly related to IT, but it's an example from another industry, and it's what happened with Kodak. The example of Kodak that everybody knows, where Kodak's now functionally bankrupt. But when Sony came out with the digital camera, and Kodak wasn't stupid. First of all, they developed a digital camera before Sony did. But beyond that, they did an analysis of whether it was going to be a threat to them. And they asked themselves, well, is Sony making film? And the answer was no, they have a digital camera. Well, is Sony making chemicals? And the answer, no, they don't make chemicals. And they said, well, we make all of our money off of film and chemicals, so it's not a threat to us. And of course, they got it wrong, and they're essentially bankrupt. What was it that they got wrong? They didn't fundamentally understand the business that they were in. They thought that they were in the film or in the chemicals business, but that's wrong. They were in the images business. So how's that relevant to healthcare? I think most of us, CEOs of hospitals and other things, we don't understand the business we're in. We think that we're in what we call in the United States the heads in beds business. In other words, I've got a hospital, I've got a bunch of beds, and I need to fill those beds. And that's true today. And every bed that I fill, the more money I'll make. Any hospital CEO that believes fundamentally that she is in the heads and beds business is making a big mistake, though. Because we're not really in the heads and beds business. We're in the healthcare business. And healthcare can and will be provided in lots of different places outside of a hospital. The sooner that those of us that provide healthcare understand that and move towards doing that with the help of all of you, IT, digital things, and other things, the sooner that we understand that and start to really understand that we're in the healthcare business wherever that's provided, however that's provided, out in the community, in a physician office, in an ambulatory site, or in a patient's home, the better it will be for us, and more importantly, the better it will be for patients. So any solution that any of you develop to help us get there is welcome and long overdue.
So, Carl and Michael, could you reflect on the same question? And I just also want to highlight something that Kevin said. I said that he still doesn't see maybe a strong enough offering from the industry. And you as people that invest heavily on startups that are supposed to provide those kind of offerings, could you also relate to that point as well? Thanks.
Maybe I'll make an observation on what Kevin's thesis. I think we're in an interesting transition point in the healthcare tech space. In the last 2 years, in 14 and 15, we saw an explosion of capital come into the category. I've seen data where there are 1,800 or 2,000 new companies have been created. I think many of them are more narrow point solutions to solve Kevin's old problems. And so I'm reflecting on your original question, which was, what does 10 years look like from now? And I'm thinking about some of our portfolio companies, and I won't give the commercial, but you mentioned Iora Health. Iora Health, if I were to describe in a sentence, you'd sort of roll your eyes. It's reinventing primary care. Well, it's profoundly disruptive. It's really around the payment model. And the entrepreneur there, which is a wonderful Boston-based company, I encourage all of you to visit, said, I'm going to scrap all the entire operating systems, all the legacy systems. I'm going to build my own system. It's not a billing service infrastructure. It's a value-based care delivery model. And we now have 35 practices going to hopefully several hundred practices. The impact on outcomes on these populations that they're managing is profound. And Kevin could certainly drive those same impacts, but on relatively meaningfully less capital and infrastructure, fixed assets. We're managing 45,000 people and showing in a couple of years profound impact on outcomes. That came about because they reinvented a care delivery model. I think a lot of what we're excited about and investors are excited about are these novel service models that are sort of tech-enabled, using a lot of the solutions in the market. My fear is a lot of what's been funded in the last couple of years are very narrow solutions solving old problems.
I think another thing that comes out of what you're talking about, maybe more generally, is the shift of focus to the outpatient setting from the hospital setting. And I don't know, Carl, could you answer the first question, but also maybe relate to do you see the same trend in your portfolio, in the investment portfolio that you are managing?
Sure, happy to. So I think what might be helpful is to talk, you mentioned media, financial services, and healthcare, and those are all very different business models. So media, you think media companies sell you media. They don't do that. They sell your eyeballs to advertisers. That's the business model of media. And then financial services is basically about losing money on almost everybody and then making it all back on a very small percentage of people who carry a credit card balance or have high assets. So banks lose money on almost everybody in the branch except for the people with enough assets to allow them to lend to others. Healthcare is kind of the opposite of that, which is everybody pays, there's a premium that pays for more than what you're going to consume because there's a small percentage of the people who are going to consume way more than anybody else. If they have a serious medical condition or chronic illness or need a very expensive medication. So I think it's important to have the context. I would argue that none of these industries have really gone that far yet with digital technology. I mean, financial services is still kind of a joke in the US. We use paper checks all the time. No one does that in Scandinavia anymore. We're just now starting to see applications in financial services that bring about the promise. So you can now do your Apple Pay with your phone, or you can use Venmo to share a bill at a restaurant with somebody, but only if you're under age 30, because I wouldn't know how to do that. Stripe allows vendors to get paid with a credit card for an artwork sale on a street corner. What's happening there, I think, is instructive because we just now have the infrastructure in financial services, and people have figured out how to use software to hack their way in to allow applications to run on top of infrastructure. So my own personal view is and I think all panels should start with provocative statements because then we can talk about them, is I think EMRs, electronic health records, are not the solution. I think they're the equivalent of an accounting system at a company. Everyone has to have a general ledger that's audited, and there has to be an official record, and there's regulations. But there's no way for a piece of software like that to do all the things we want it to do. And in fact, it's currently counterproductive. Most physicians are spending 40% of their time now, inside of the system. Residents, at least, 40% of their time. So I think what we need is infrastructure that people can then build apps on top of. And so a very quick analogy, when you return your car at a rental car place today, the person comes out in the parking lot and barcodes your car and swipes your credit card and off you go. And that's a great experience. That system is not the general ledger system of Hertz, but it talks to the general ledger system of Hertz. So now that we have electronic health records in place, and that's important for regulation and other reasons, I think they're increasingly going to be less important. They're going to be sort of the equivalent of the general ledger system. And as Michael was saying, the point systems that enable a better process or better experience will be built on top of that infrastructure. So just like you're building, Apple Pay on top of the financial infrastructure, other solutions will be built on top of that. And the biggest thing missing today is a data network that allows people to build apps on top of it. And while we're plugging companies, we were the first investors in a company called Patient Ping, which is just helping doctors figure out where's my patient. And so they're wiring up all the systems at hospitals for admission and discharge and at skilled nursing facilities, so you can track where your patients are. And that will create a network that people can build apps on top of.
I just want to respond to the comment you made about electronic health records. Actually, I don't think it's that controversial. I think most people would agree that we get very little from a traditional electronic health record today. My position on that, as a potential consumer of an electronic health record, is that the amount of money and time that we, especially in the hospital industry, spend on EHRs is obscene. And is not going to be compatible with what we need to do in the future. And while I couldn't tell you what's going to come along to replace the idea of a traditional electronic health record, I don't think there's any question that in the next 5, 10 years, it's a little bit like timing the market. I can't tell you exactly when. Something's going to come along that will be 1/10 or 1/50th the cost of what we now use, but will be 50 or 100 times better. And I can tell you that there are some of us who are now very reluctant to spend the kind of monies that are needed to put in traditional electronic health records. I'm not sure that I want to be the last CEO to spend $500 million before something comes along that's 10 times better, that's $10 million. Again, the challenge for us is to figure out exactly when that's going to happen and what that's going to be. If I knew that, I probably wouldn't be running a hospital. I'd probably be at that company. But I'm convinced it's going to happen.
So just to just to follow up on the last discussion, if you think about the digital health, fair to say that the EHR is something that does data storage and management. But if you want to think about the end-to-end elements that you need to have in a system that is actually a working system, you also need to think about at least 3 other elements. One of them is data collection. So how do you actually collect data into that EHR system? That's something that still has its own challenges. There's a lot of innovation around that with all the wearables that we can envision people are going to put on themselves going forward already now. But there are some unresolved challenges in the space of data collection. For example, how after a visit, a physician summarizes the data that is relevant from that visit in the most efficient way, in the most productive way that will allow us to care for the patient later on. And then the third element is what we call the analytics. So how do you take the data and actually transform it to something that actually informs decisions? A very big challenge. But maybe overlay everything, all of this, is the challenge of how you take all of these elements and integrate them into a working end-to-end system, something that customers, be it Kevin or other players in the healthcare industry, can use. And what I would like to ask the panel members is, relating to the different elements, data collection, data storage and management, analytics, and the end-to-end solutions, if you can give us your perspective about the current state of affairs, what are the needs and what kind of outcomes, both quality and cost related outcomes, should be targeted by those solutions. Carl, why don't you start?
Well, some people don't know that when Athenahealth was started, and you'll be hearing from Jonathan soon, who's the CEO of Athena, we actually started an OBGYN practice management company. We were going to manage a midwifery-based delivery system, and that business model totally failed. It was too close to the physician. There are all kinds of reasons why. And we built AthenaNet as a way to run the medical practices that we were responsible for. But I remember a physician in Rhode Island, Lynn Lowe, told me once that as an OBGYN, all the information he needs to give great care to a patient who's about to deliver a baby could be put on a 3x5 note card. You know, he needs to know allergies, he needs to know how many babies they've had previously and how those turned out. You know, there's 4 or 5 things he needs to know, and that's pretty much it, you know, Rh negative or not. So I think we often overstate because people imagine an electronic health record as being essentially this chronicle of who you are and everything that's ever happened to you, it becomes unwieldy. And I personally think that what's more important is just to get the facts right. So, you know, which prescriptions have you been given and when? What's the blood work? What were the values? I think if we focus on sort of transaction levels, so if you think of it, to use your analogy, like financial services, more like the credit card statement. You know, Carl went to Starbucks on Thursday and he bought a latte. Keep it very sort of transactional. I think that's more helpful because you can share data about someone. Carl had this allergy on this, you know, was diagnosed with this allergy on this day at this point in time. That's a useful fact. Knowing what the doctor thought, and I went through 4 bodily systems, and I talked about his grandmother and all this, I think that might be helpful at times to capture. I don't think it amounts to being a fact that someone else later can act on. So I would focus on transactions, and then answer your question, and going back to that note card, you've said something yesterday that I'm going to quote like for the rest of my life, which is don't focus on the data, focus on the decision points, and then you can figure out what data is needed. And I think of that doctor with the note card, he had all the data he needed to give good care based on the decisions he would need to make during labor and delivery. So I think if we focus on the basics, we'll get a lot further than if we try to capture, you know, natural language processing and all of these interpretations. Most doctors I know are not particularly interested in some other doctor's interpretation from 3 years ago because they don't know that physician. They don't know if they're good or bad. The world's changed. Just give me the facts, and that's a good place to start.
Michael, any reflection on that?
No, it's hard to disagree with that. Again, I'm thinking about as an early stage investor, I think one of the common issues the entrepreneurs are confronting, obviously interoperability is a huge problem, and so we end up defaulting to a lot of point solutions, and then how do you productize that? And the analytics space we think is wildly exciting, but it's not clear how the customer wants to buy, what they're actually looking for. There's a whole set of product-related issues, and I think consequently, again, back to what I said earlier, I think that we're at this funny transition point where there are almost too many very narrow solutions, particularly in the analytics space, where there's an ability to get some really novel insight, but how do you actually act upon it? How do you create value from that?
So if I may challenge you guys, could you tell us also what yes and not only what no? So, what would draw your attention, Kevin, as a CEO of a hospital? What kind of solutions, what kind of outcomes in the quality space and the cost space you would be interested to affect, and what kind of solutions you can imagine would be interesting for you?
Well, let me be Israeli and not answer your question, and then, but I'll answer it. But I will answer. I'd say, you know, I mean, I think that original question, and then this one. So what? Yes, that original question. Well, we have all these pieces. How do they work together? How should they work together? Do they work together? And then what actually works is a good one, because, you know, I'm pitched an idea or a company almost on a daily basis. Honestly, if my chief of staff were to allow it, my day would be filled with pitches from companies that want to show me a solution. And almost everybody that shows me a solution has something that's good, but most frequently it's the equivalent of, this idea solves left toe pain. And it's great. And I've got outcomes to show you it's really good. Why don't you want to buy it? I've got really good outcomes to show that it solves left toe pain. So first of all, I think people frequently miss really what we're looking for. And make sure, as you think about ideas, that you're solving a problem we have, not coming up with a solution for a problem we don't have. But more importantly, if it's an idea that only solves one piece of a puzzle but leaves the other roadblocks in place, we're not going to be interested. Because while it may look interesting and it solves that piece, if the other roadblocks are in place, it's just as much of a problem for you. So I would encourage all of you to go back and think about it from our perspective. Is it really going to solve a host of problems that gets us to a real change, or is it going to be very, very siloed? And most of what I see is siloed.
Okay, so we don't have, unfortunately, we don't have a lot of time today, but what I want to talk about next is the opportunity that many of you could find in Massachusetts and in the Boston area. And it's fair to say, I think I'm probably subjective being from that area, but it's fair to say that we have currently the world's largest and most vibrant ecosystem for digital health and bioinformatics innovation. And I want to mention a few aspects why I believe that's correct. First and foremost, we have some of the most prestigious hospitals and academic medical centers in the world. The second is that we have some of the most prestigious universities in the world. But over the last 10 years, I think it's we have been observing essentially most of the major R&D labs of some of the most major players in that space moving their resources and labs into the Boston area. So all of these are facts, but I want to highlight two other aspects that maybe are less obvious, especially to this crowd. One of them has to do with the culture of our area, and I think the governor called it the DNA. We don't all have all of these pieces, but we also have a very, very strong culture of collaboration between all of these pieces that I think makes us very, very unique in that respect. And that's kind of a very significant aspect, I believe, of making this Massachusetts a very attractive place for people like you. And maybe the last aspect I would like to mention is the regulatory environment. It's fair to say, and you all heard about the federal reform in the US, but Massachusetts is essentially 5 to 10 years ahead of the curve. And if you go to Palo Alto or other areas, we probably in Massachusetts live their future at the moment. I'm stealing that from Kevin. I heard Kevin said that. So we are essentially living, Israel is still with no shame, as you know. So what I want to ask the panel members is what kind of advice you would give to someone here in the audience that want to start to penetrate the U.S. market, and why would you, how would you explain in your own words why Massachusetts is a good place to start? Michael, you want to start?
So the list is even longer than that. 25% of all venture capital is managed probably within 5 miles of Charlie's office. We have extraordinary set of entrepreneurs. We have great lawyers. We have great investment bankers. So the ecosystem is hard to build, and we built it years and years ago. And it's a very powerful ecosystem for that. I think my short advice is come to events like this, come to the events that we host in Boston, and just begin to immerse yourself in that soup of great activity. But you need all of those ingredients to be sustainably enduring.
One quick comment on the U.S. healthcare system, and then I'll answer your question. I like that you don't have to answer questions in Israel. I didn't know that. That's great to know.
I'm pretty excited.
Yeah. This is Charlie's kind of country. Okay. People often wonder why the U.S. healthcare system is so messed up. And one of the reasons is that we have all of the healthcare systems. So if you're a veteran, it's the British system. We build hospitals, we employ doctors, and it's a national socialized system for veterans. If you're old, it's the Canadian system. Private delivery, federal payment. If you're in a private company, it's a private system. If you're poor, it's like the Uganda free clinic. You know, we've got it all. And so that's inefficient to have all these systems on top of each other. But if you're an entrepreneur, what's kind of nice is you have a lot of different choices for where you could try to innovate. I think the reason to come to Massachusetts is because of the talent. The universities produce a lot of talented people who you can hire. And the proximity, I would say, would be the second reason vis-a-vis Silicon Valley. New York's it's Wall Street. You know, don't go to New York. The other thing I would point out, though, is we have big academic medical centers. I don't think big academic medical centers are usually the place to innovate something that's systemic. It's usually about the next big breakthrough. I don't envy Kevin's job because he has so many things he has to worry about. He has to be in charge of research and teaching and community care and advances and all this. So it's a lot of different things. But we also have startups that have done well in Athena, in Boston, including Athena, which is an internet-based system. So Jonathan told me to plug Athena. You can work with Athena. They have a whole thing called More Disruption, Please, where they invite startups to come in and use their database and get their client base to experiment. So I think those are probably the main selling points, but I also think you're probably coming for the talent because it's a national market, and where you roll out, the odds that it'll be in Massachusetts are low just because it's only one place. But you'd want to be there for the talent, and then if your first customer happens to be in New York or Pittsburgh or whatever, that's fine. It might be in Boston, and that's convenient, but you'd go to Boston for the talent. And the governor.
Just one other point. I mean, I think, and the governor. You know, you heard all of those things are true. You've got a confluence, as you've heard, of really the mecca of medicine internationally, and very smart people. But just to get to your earlier point, there are pressures in Massachusetts around healthcare that are, at the moment, unique and causing really what we call a burning platform for change. I have only been in Massachusetts for 5 years. I was in California before that, but I was recently back in California, asked to come out and give grand rounds, and they were sort of needling me about, am I crazy having left California for the healthcare environment of Massachusetts? Because Massachusetts, it's tough. Margins are very slim for healthcare companies, for hospitals. Competition is very stiff, and we're all migrating very quickly as healthcare institutions to new business models. And they were, you know, sort of incredulous that I would have left California, but, well, the weather is better, although I reminded them that they have earthquakes. But more importantly, they have margins of 10 or 12 or 13%, and, you know, they're 100% fee for service. And I did look at them and smiled, and I said, well, enjoy it while you can, because I'm from your future. And I think, though, the point of that is that what is going on in Massachusetts around healthcare delivery is really the future of a lot of what will go on in the rest of the country. We are leading the way, for better and for worse. We're leading the way. People look to us for what the future may look like. And I believe, at the moment, we may not be completely representative of the rest of the country, but if you can affect change in Massachusetts, that will have importance well beyond the borders of this state. So I think it's a great place to come and work with us.
So I think that maybe we can take the last 5 minutes to open it for questions from the crowd, from the audience. So any questions, anybody that wants to ask? Yes, go ahead.
Hi, my name is Naomi, and I think as a startup we have a lot of issues to deal with. We have three main focuses, which is, one is to really create a great product for a important need. The second is how to penetrate, but the third would be where the money is. So since this is a panel that understands that a little bit, and we've been looking a little bit about Obamacare and trying to understand where for digital health, the money is, I don't know what's going on, the changes. Where do you think things are going to kind of transition with Trump, the threats about the Obamacare, and where would someone that is looking to make money or maybe the market and make money in the digital health arena, what should we be looking for? Where should our insights go to?
Anybody wants to pick it up?
Do you mean reimbursement money for services in healthcare, or do you mean venture capital money, or both? Oh, reimbursement. I think it's a period of tremendous uncertainty because of Trump. People don't know. I don't think he knows half the time, right? When he's not busy attacking the CIA, he'll think about healthcare.
Check your tweet. Maybe you found the answer.
Right. So I honestly, we have an LP meeting this week, and there's a chart that one of our competitor firms, Bessemer, made that they let us borrow, which has concentric circles. Here's Obama with an Obama symbol, and here's Trump with the hair, this little hair symbol, and then there's overlap in certain things. It's unclear, for example, if value-based care is or is not a shared objective, because Price, who's the new head of HHS, is opposed to it as a physician officially, but the campaign says they're in favor of it. We know Ryan's in favor of it. So it's tremendous uncertainty, and so I'm glad we closed our fifth fund, 2 months ago before all the uncertainty. But I really think it's a wait and see. We're still making investments with things that make sense, but I think people really don't know. My guess would be that, here's my fear. I think, this is Carl just mouthing off, I think that military spending will go up. I think taxes will go down, which means deficits will go up. I think that the most likely target, if you're in Washington, is Medicaid, because it's not the natural constituency for the party in power, and the problem there is a lot of the times the way we make things better with healthcare is spending more on essential services to get at the social determinants of health to reduce the expensive stuff. So I really worry that they're just going to cut Medicaid, and then we're going to kind of go back to some of the imbalances we've had previously. That's my fear. But I have a feeling that certain things like Medicare Advantage are a huge source of strength. So if it's for the elderly and it's focused on things that are covered by Medicare entirely and don't depend on Medicaid, I think there's going to be more opportunity to innovate there, because more and more of the care will be directed by private plans that can do innovative things and invest where there's a positive ROI. So I would probably focus more on Medicare, less on Medicaid. And as for the companies, I think there's always been a huge opportunity to go to self-insured companies that are accountable for the whole dollar, and convince them to do something that makes sense for their employees.
I guess I'd just say, anybody that tells you that they know exactly where this is going to go is either lying or a consultant, or hopefully they're not. But of course, we don't know exactly, not at the federal level, not anywhere else. But what we do know for sure is that healthcare is way too expensive, and there is nothing that happened in the election that changes that simple fact. And it doesn't matter what side of the political spectrum you're on. That's not an ideological question to a large degree. It's bipartisan. Healthcare is way too expensive, and we've got to crack that nut. Not only is healthcare too expensive, it's way too expensive and way too ineffective. The combination of those two things is not a political question. How we solve that may be a political question, but that's not a political question. That is not that. Those two facts are not going away. And I think certainly in Massachusetts we recognize that. The governor was quick to say after the election that independent of anything that happens at the national level, we are going to continue down the path that we've already started of working on making sure that we provide really high quality care at a lower cost. And I think that that's going to be true independent of any administration out there. Anybody, any one of you that helps us focus on those things, you're focusing on the right thing. I don't know if it's going to be called Accountable Care Organization or anything else, but what I know is healthcare is too expensive and too ineffective. That's true now. That was true 5 years ago, and it'll probably be true next year. Help us with that.
Okay, so with that, I would like to thank all the panel members and thank you guys, and we'll continue with the program. Thank you very much.